So the best treatment for acute lymphoblastic leukemia. Here your options: chemotherapy, radiotherapy, and bone marrow transplantation. Bone marrow transplantation is best because it is the permanent cure. All others, you give chemotherapy, again you will have the remission. Case scenario of ALL, treatment chemotherapy, treatment induction of remission, then consolidation of remission, then if relapsed, reinduction of remission, then bone marrow transplantation. Let's see, it's not clear here. We'll see in the other book. This one, case scenario of ALL, treatment is chemotherapy, induction of remission, then consolidation of remission, then if relapse, reinduction of remission, then bone marrow transplantation. I don't know what do they mean by consolidation here. I have to check. Of acute lymphoblastic leukemia is induction of remission, then consolidation of remission, then if relapse, reinduction of remission, then bone marrow transplantation. I want to know what is consolidation. So, consolidation treatment is also called post-remission therapy. The goal of consolidation treatment for acute myeloid leukemia is to kill any remaining leukemia cells in the body and prevent leukemia from coming back. It is done to maintain complete remission and prevent relapse. So consolidation means they try to, consolidation is a treatment also called post-remission therapy. The goal of consolidation treatment is to kill the remaining leukemic cells in the body and prevent leukemia from coming back. It is done to maintain complete remission and to prevent relapse. So, consolidation in ALL. Consolidation or intensification treatment of acute lymphoblastic leukemia is given to prevent leukemia cells from coming back. The consolidation treatment phase begins once you get into remission after induction treatment. So, first is induction. Then if there is remission, then you will come to consolidation. So the steps is induction of remission, then consolidation of remission. Then if relapsed, reinduction of remission, then bone marrow transplantation. Child with reduced HB, reduced WBCs, reduced platelets, that means pancytopenia and bleeding. You will give whole blood transfusion. Same here. Child with HB, reduced WBCs, reduced platelets and bleeding, we will give whole blood transfusion. Platelets. The lifespan is 7 to 10 hours. More younger, more active, more older, more bigger. About platelets, the average lifespan is not 7 to 10 hours. It is 7 to 10 days. It seems the average lifespan of platelets is 7 to 10 days. We have to remember that the average lifespan of platelets is 7 to 10 days. And the more younger, more active. More younger the platelets are, more active they are. So platelets more younger, more active. About the platelets, the average lifespan is 7 to 10 days. Next is sickle cell disease. There is convulsion. Sickle cell disease, convulsion, resolved spontaneously without treatment. There is paresthesia, inability to move limb, causes stroke. We know that in sickle cell disease, we will have stroke. So this child presented with convulsion that resolved spontaneously without treatment. And also there is paresthesia plus inability to move limb. That means it has led to stroke. Next, same question here. Sickle cell disease plus convulsion resolved spontaneously without treatment. Paresthesia, inability to move limb causes stroke. Now, arthritis in sickle cell disease is caused by Salmonella. Salmonella is the organism which causes arthritis in sickle cell disease. Same, arthritis in sickle cell disease is caused by Salmonella. Next is severe aplastic anemia with severe bone marrow failure. To diagnose the absolute neutrophil number, what is the absolute neutrophil count? Should be one. Neutrophils less than 1,500, platelets less than 20,000, neutrophils less than 500, platelets less than 20,000, neutrophils less than 200, platelets less than 20,000 and 10,000. He is speaking here severe aplastic anemia with severe bone marrow. The two absolute neutrophil number, let's check. He is telling less than 500, but let's check. Here also, in this book also, it's given severe aplastic anemia with severe bone marrow failure. To diagnose, absolute neutrophil number is less than 500, less than 20,000. But I will check and confirm that. So what are the criteria for severe aplastic anemia? Severe aplastic anemia is defined as marrow cellularity less than 25% plus at least two of the following peripheral blood findings. Okay, marrow cellularity should be less than 25% plus at least two of the following peripheral findings, that is neutrophils less than 500. Okay, and platelets less than 20,000 per deciliter. Reticulocytes less than 20,000 per deciliter. So here he has given severe aplastic anemia. Absolute neutrophil count should be less than 500 per deciliter and platelets less than 20,000 per deciliter. So it is correct. Because here it's given severe aplastic anemia is defined as marrow cellularity less than 25% plus neutrophil count less than 0.5 into 10 he's telling. I think into 10 to the power of 9 it is. So it will be around 500 per deciliter and here it's given liter. So, and platelets less than 20,000 per deciliter. And same thing, reticulocytes less than 20,000 per deciliter. A case of portal hypertension with hematemesis, low hemoglobin, normal WBCs and platelet. Others normal. You must do first correct hemoglobin. So a case of portal hypertension with low hemoglobin and there is hematemesis. Otherwise, there is normal WBCs, normal platelets. What we must do? We must correct the hemoglobin first. Same, a case of portal hypertension with hematemesis, low hemoglobin, normal WBCs, platelets and others. Normal you must do first. The options here they have given is injection sclerotherapy. You should give the sclerotherapy or correct HB, or you should give vitamin K and others. So first thing is all these things you will do. You will give injection of sclerotherapy. But the first thing is to correct hemoglobin. Okay. To monitor the heparin dose, what is important? To monitor the heparin dose, APTT, that is partial thromboplastin time is very important. PPT. PPT is very important for monitoring the heparin dose. Let's check in Google. Expression and monitoring of heparin. Activated partial thromboplastin time, APTT, is maintained at 1.5 to 2.5 times the patient's pre-treatment value. So how do you monitor the heparin is you monitor by values of APTT. It has to be maintained between 1.5 to 2.5 times the pre-treatment value. So the next 10-year-old child with fever, fatigue, splenomegaly, 10-year-old child with fever, fatigue, splenomegaly since 4 weeks. His weight is 16 kg. Slide of blood film. What is the most important curative treatment? So fever, fatigue, splenomegaly since 4 weeks. I don't know, positive slide of blood film for what? It is not given here. Weight 16 kg. He's telling radiotherapy, hydroxyurea, bone marrow transplantation. Curative treatment, if it is sickle cell disease, it will be bone marrow transplantation. But I don't know what maybe it is thalassemia or what, it is not mentioned here. Let's check in the other slide what's given. 10-year-old child with fever, fatigue, and splenomegaly in 4 weeks, weight 16 kg, plus slide of blood film. What is the most likely curative treatment? Bone marrow transplantation. Maybe this is sickle cell disease or thalassemia, something. That's why they have written bone marrow transplantation. The question is not clear. Diagnosis of beta thalassemia. For diagnosis of beta thalassemia,
Dito ka, hemoglobin A2 normal.
we should know the, we can study the, better we have to go through the hemoglobin electrophoresis. Okay, what is it in trait and what is it in major? So he is telling in major, we see more of hemoglobin F. Whereas in trait, we see some HbA2 value is there. For example, like HbA2 more than 3.5. But more in major, more HbF will be there. But I think better to go through the Hb electrophoresis. It will be a revision. Other slide. Same he has given diagnosis of beta thalassemia trait. See, he has written diagnosis of beta thalassemia trait. We have to check HbA2. And HbA2 will be more than 3.5 in these patients. But for major, HbF will be more than 70%. Let's go and check the Hb electro. So, if thalassemia is still suspected, hemoglobin electrophoresis may help to diagnose the condition. Hemoglobin electrophoresis with beta thalassemia trait is usually has reduced or absent HbA, elevated levels of HbA2 and increased HbF. Beta thalassemia major is diagnosed if the earliest hemoglobin electrophoresis is recorded in the medical record has, you see, 10 to 90% of HbF concentration accompanied by splenomegaly or a history of splenectomy giving a distinct pattern on Hb electrophoresis. HbA or HbA2 with or without HbF or no abnormal Hb fraction. So as I understand, in cases of beta thalassemia major, the HbF will be too much more. That is 10 to 90% of HbF will be more. But in thalassemia trait, HbF will be around 70% and very low HbA with or without HbA, and HbA2 will be more than 3.5. See here it is written. Reduced or absent HbA, elevated levels of HbA2 and increased HbF. But I think HbA should be there in minor. Let's check for minor. A common a common confounding factor in hemoglobin electrophoresis is the concomitant iron deficiency that masks underlying beta thalassemia minor. The results of electrophoresis pattern appears normal. This is because iron deficiency anemia normalizes HbA2. That is the key finding of beta thalassemia minor. We can say trait means some amount of HbA will be there. Okay, that's why they were telling that beta thalassemia trait sometimes will be treated as iron deficiency anemia. See, both in beta thalassemia trait and in major, there is some amount of HbA2. HbA2 is there. But in beta thalassemia major, almost there is no HbA. There is no HbA at all. But in beta thalassemia trait, quite HbA is there. It will be like normal only. It will be like normal only. You can see the HbF is less in trait, but it is more, almost 90% in major. So most of it will be, so for the major, the electrophoresis is, most of it will be, HbF will be 90%, and with or without very small quantity of HbA, and there will be around 3.5% of HbA2 in both. We can see this slide and remember. You can take the picture from your phone screenshot if you want. Okay.
ميتريت نلاقي لا زال فيه هيموجلوبين ايه، ونلاقي الاي 2 زايده. بيتا ثلاسيميا ميجور بنلاقي فيه هيموجلوبين اف واضح جدا، هيموجلوبين ايه قل قوي، هيموجلوبين اي 2 يكون زايد شويه. الاف في بيتا ثلاسيميا ميجور. طيب السيكل سيل تريت بنلاقي هيموجلوبين اس موجود ومعاه ايه تركيبه اي اس، والاس اقل من 50%. طب سيكل سيل انيميا نلاقي اس كتير فوق ال 50% ومفيش ايه خالص، وساعات نلاقي فيه شويه اف صغيرين.
So this is what? Diagnosis of beta thalassemia trait. Again, there will be HbA2 in both. HbA2 and also in beta thalassemia minor. He's telling here HbA2 will be more than 3.5, which we saw in the slide. HbF more than 70%, but we saw almost 90% in major. Let's see in the other slide what he has given. Same thing. He says that diagnosis of beta thalassemia major, HbF will be too much in those cases. And for minor, HbA2 will be more than 3.5. And also in minor, there will be decreased iron. Next question. 6 months old, splenomegaly, pallor, HB9, retics 10, MCV 86, other labs normal. We should know the normal value of MCV. Okay, so splenomegaly, pallor, HB9, retics 10, MCV 86, other labs normal. He's telling hereditary spirocytosis. Why? In hereditary spirocytosis, we see spirocytes. What is the MCV of spirocytes? Is it normal or it should be more?
More.
More. So, normal MCV. Normal MCV. So normal MCV is 80 to 100 in MCV.
According to the age, the patient was 6.
For 6 months